Hello, everybody, and welcome. I'm Vicki Petersen. I am the Iowa EMSC Program Director, and I would like to welcome you to Social Poisoning, Drugs and Dangers in the Modern World. This is the 12th topic that we have done in our free pediatric education series. It's also the 5th symposium that we've done with Children's Minnesota using their education and training system for continuing ed credit. Children's does require that you set up an account to get credit through them, and that has a few benefits for you. One is a quick turnaround on your certificates. The other one is that once you set up that account, you can view any education that's on their site. So you might want to look around and see if there's anything else that you want to view. And Children's Minnesota also issues EMS credit. So EMS providers can get CEUs the same way as other registrants. And that's a faster response time for you as well. If your EMS provider is watching in a group, that credit will come from your EMSC program manager from your state. So just be sure to submit a list or a roster, depending on what you do in your state, of the folks who are attending in the group to your EMSC program manager by end of day Thursday, so we can provide that credit. By the way, no need to put your name in the chat. Sometimes webinars have you do that so you can prove that you attended. Zoom will keep track of that for us and will give us a record and show us all of your viewing time. We won't take a scheduled break really during this presentation, but please feel free to step out if you need one. Before we move into our presentation tonight, I do want to tell you a little bit about the folks who bring you these symposiums. Next slide, please. There we go. These symposiums are a product of your state EMSC program. EMSC stands for Emergency Medical Services for Children, and it's the only federal funded program in the country that's dedicated to helping emergency care providers give the very best care for kids. Each state and territory in the United States has an EMSC program that's funded in all or in part by one grant from the federal government. Our group is called Heartland EMS for Children Coalition, or HECC. We're a group of Midwestern EMSC program managers from Iowa, Kansas, Minnesota, Nebraska, North Dakota, and South Dakota. And we have kind of banded together to pool our resources and our ideas and our thoughts to maximize our contribution in our own states and to help each other. The behind the scenes members of this team that you can't see but are working very hard are Corolla Lauck from South Dakota, Kjelsey Polzin from Minnesota, Jessica Baker from Kansas, and Chettie Greer from North Dakota. Our dear friend, Debbie Kuhn from Nebraska, has retired recently, and to my knowledge, her position has not yet been filled. But if you are from Nebraska and you do need assistance, your contact is Tim Wilson. Contact information for all of us will be provided on a slide that's coming up, and then also one at the end of the presentation. These pediatric symposiums were born during the pandemic from a lot of discussions about how we could help bring you continuing education during a challenging time. And since September of 2020, we have offered 47 hours of pediatric continuing ed, all free, to EMS practitioners, physicians, nurses, APPs, and more, on topics including children with special healthcare needs, burns, human trafficking, provider resilience, youth suicide, traumatic brain injury, just to name a few. I also want to let you know that all attendees are in listen-only mode. That means that your mics and your webcams are automatically disabled. If you have any technical issues, or you need some support, or you just have a comment, please use the chat box for that, and we'll respond as we're able. If you have questions that you'd like us to ask the presenters in the question and answer period following the presentation, please put those in the Q&A box, and we'll get to as many of them as we have time for. Finally, all attendees must be present for at least 100 minutes and complete an evaluation to receive their 2 hours of continuing ed credit. Once the symposium is complete, you can access your Children's Minnesota account site, fill out the evaluation, and get your credit quickly. If you don't sign on to your Children's Minnesota account right away, that's okay. You'll also get an email about completing that evaluation. Your certificates can be found in your account after the evaluations are received. Please print them or save them for your records. And the group EMS watchers, you will get credit from your state's program manager. Please remember, you do need to complete that evaluation within 30 days of today to receive credit. After that, you will no longer be able to access your certificate. As always, if you have a problem or a question, please reach out to your state EMSC program manager, and we'd be happy to help you. This is our contact information. Again, we'll show it again at the end of our session. For our EMS friends, has your EMS agency taken the pre-hospital pediatric readiness project assessment yet? It's a brand new national survey, and the data that it collects will be really important. For your EMS agency, you will get immediate feedback after the survey on your readiness to care for children and some information on areas that you might want to work on if you choose to do that. On a statewide and national level, aggregate data will show EMSC programs what we can focus on to help you the most and how we're doing as a state and as a nation in taking care of our kids in emergencies. Your agency level data is completely confidential and your survey results belong to you. Only de-identified aggregate data will be used in a public facing way. So no need to worry about that. This survey is similar to the hospital survey that's been in existence for a few years called the National Pediatric Readiness Project. And the data on that project already shows that by improving readiness scores, hospitals are improving their care and outcomes for kids. And we expect the same thing on the EMS side. However, it's really important with this survey, as with all surveys, that we have a high response rate to this survey. Otherwise, it won't accurately represent our state or our nation. So please complete that survey if it comes to you. And if you're not the recipient, please check with your service director to make sure that it's been completed. This is accreditation information from Children's of Minnesota, who has been good enough to give us credit for all of our attendees. And then disclaimers, and then we have no disclosures. Okay, housekeeping is done. Now on to our presentation. We have two presenters this evening, both from the Minnesota Poison Control System. Both are also active members of the Minnesota EMS for Children Advisory Committee. Kirk Hughes is an RN working as certified specialist in poison information and as the education director for the Minnesota Poison Control System, where he's managed over 86,000 tox-related medical cases. He has been an active member of the Minnesota EMS for Children Advisory Committee since 2009. Kirk recently retired from the fire service after 27 years of being a member of the City of Ramsey Fire Department and Brooklyn Park Fire Department, and being an EMS training officer for the Lexington Fire Department. He has also worked as an investigator for the Hennepin Medical Examiner's Office and is a hazmat technician. His publications appear in the Journal of Perinatology and the Journal of Clinical Toxicology. Mandy Slag has been working at the Poison Center as a Poison Center educator for the Minnesota Poison Control System for 3 years. She has worked in public health for more than 11 years. Her past public health roles include school nursing, which is not for the faint of heart, and for the North Dakota Department of Health as a family planning nurse consultant and an injury prevention program director. Her education includes a BSN from the University of Mary in Bismarck, North Dakota, and a Master of Public Health degree from the University of North Dakota in Grand Forks. Please help me welcome Kirk and Mandy.
Thank you very much. You guys can hear me okay? Perfect. Thank you to the coalition for hosting this, number one. I know I found it valuable in my EMS role and letting my fellow EMS people know that EMSC does exist, because a lot of them don't. So all you EMS folks that are out there, please let your fellow EMS people in your respective states know about this. I actually recently also had a Carter kit secured and delivered to the fire department that I retired last from, and they've already put it into use. So kind of exciting and good resources here. So really wonderful agencies here. Thank you so much for the support. So we'll jump into it because we have a lot to cover here. So with that, I don't have any conflicts of interest to disclose. Once again, a reminder that if you don't want to go ahead and see these guys looking down at you from the examination table, make sure you wear your tinfoil hat on July 2nd, wherever you're at, so that you don't get taken and probed. One of the biggest things that I love about doing in my job is letting people know that we can take the fear out of toxicology, poisonings, those sorts of things by utilizing your poison center. And whether you're utilizing the Minnesota Poison Control System or whatever poison control system covers your state, your respective states, we all meet the same accreditation. We're all very helpful. And I like to say that me personally, I'm not speaking for anybody else I work with. I know two things. I'm not the brightest bulb personally, but I know toxicology better than probably 95% of ER docs, and I know how to breed. My compatriots and people at other poison centers are a lot smarter than me, so they know a lot more, but we're here to take the fear out of toxicology for you. When I started back in EMS 29 years ago, and before I got to the poison center side of things 25 years ago, I had no idea that the poison center existed, that I could call them as a line firefighter, working as an EMT, responding to a kid who ingested bleach and going, oh my gosh, I hope this kid doesn't die. I don't know how much stress I took off years of my life I took off from stress from responding to pediatric calls. But now that I know that they're there, this is my passion. This is why I'm very excited about doing this, because number one, toxicology and poisoning is interesting. And number two, people love to hear about it because we don't get enough of it. So, all right, just a little bit about your poison centers. We are part now, we used to be called the American Association of Poison Control Centers. We have changed it to simplify the name at the national level to America's Poison Centers. There are 55 accredited poison centers in the United States. Every state is covered. There's not necessarily one poison center per state, but there's one per region. So for example, the Minnesota Poison Control System covers the entire state of Minnesota. And then we also contract with North Dakota and South Dakota to provide the phone services, the 800 number poison helpline for them. In Texas, where everything's big, there's 5 poison centers. California has 3, but every region has a poison center, and that's really important. A 2004 Institute of Medicine report identified that regional poison centers were really the best structure to go ahead and have a poison center. And the reason for that is we're familiar with the different hospitals and what the capabilities are. We're also familiar with the flora and the fauna, fancy words for the plants and the animals and the critters that are in our areas, so that we can be more familiar with them. So please call the poison center. If you're bringing pediatric patients somewhere, I can give you an example in our state. In Minneapolis, St. Paul, the Twin Cities, we have 3 pediatric hospitals, and only one of them can do hemodialysis on a pediatric patient. And so it's important that we get them to the right hospital. We're not in the business of telling you where to go, but we just illuminate people and let them know that, hey, if you go to Masonic, for example, they're the only ones out of the 3 that can actually do hemodialysis on a pediatric patient, which can save time and hopefully improve outcome in our patients. So we're good at what we do. We know our resources, and we're regional. So I just like to throw this in here too. There's a poll up there if you guys want to go ahead. And I kind of blew it here, so I forgot about the poll. So go ahead and take the poll. So all of the above are going to be true. We are HIPAA compliant. You don't need to fear calling us. Yep, good job. We are HIPAA compliant. We're identified in the National Registry as being part of the healthcare team once we're contacted. If you don't want to share that information, I would rather have you maintain confidentiality if you're not sure about sharing it, but we're likely to hear about the patient and can figure it out usually when the ER provider calls us regarding that patient. So we're open 24/7, 365, which is part of our accreditation. And we're there to help you. And we have special certifications called SPI or CSPI. It's not as cool as it sounds. It's just Certified Specialists of Poison Information. So moving on here, this is kind of a little mnemonic that we came up with. Most of you in EMS know that we have sample for history. Well, this is what we use in toxicology. And if you can use it, great. I know a lot of people either love these or hate these. There's not many people in the middle. So if you want to go ahead and just use this, please do, because these are the types of questions that we're training our EMS and our providers as they're rotating through to go ahead and utilize in poisonings. Oh, I lost there we go. So some of the most common drugs used by decade, and obviously this isn't the most up to date, as you see 2017 is the latest one that we have here, but it gives you an idea of how things have ebbed and flowed as far as drugs of abuse go. Pain relievers. Pain relievers is kind of a catch-all, which is kind of basically means opiates. And we know that opiates are killing more people than any other drug of abuse in America, and that's been happening for at least the last decade out of all the drugs of abuse there are. Once in a while, we'll get meth maybe come up a little bit. Cocaine's coming up a little bit outside of urban areas, those sorts of things. But by and large, most of the time, it's the pain relievers and the opiates that we're seeing mostly being problematic and causing serious illness or death in people. Just another, we're seeing a lot of increase in psychedelics. So that would be your psilocybin mushrooms. This is the class of mushrooms that cause hallucinogenic things, for you to see things, to trip, that kind of stuff. So we're seeing a lot of increase in this. We're seeing a lot of states decriminalize psychedelics. So for better or for worse, I can tell you, having been a combat veteran in the Navy, that I don't personally suffer from PTSD that I know of, but I've got a lot of friends that do, and they've tried everything. And some of them are trying ketamine, microdosing ketamine, and microdosing hallucinogenic mushrooms, so that you're not actually getting high, but it's actually helping them and supposedly helping with the root of the problem. So they're reporting to me anecdotally that this is helping. And I know that the Veterans Administration, because I'm a disabled vet and I'm service connected, so I get all the information for them, that they're actually legitimately studying this now on a prospective double-blinded basis, the use of microdosing hallucinogenics in PTSD people. So more to come on that, but I think more, especially up in like Portland, Seattle, those types of areas, they have decriminalized the psychedelics, and we'll see how that pans out. So we're seeing more and more people, unintentional drug overdose deaths amongst youth. And obviously, since we're talking about pediatric patients, we can see the spikes in all these. Now, this just goes through Q3 of 2022, so pretty recent. But we're seeing a huge increase in this. And a lot of the impetus behind this is not necessarily the use of something, but it's using something that they think is being one thing and it is adulterated with something else. And we're going to talk about a bunch of those things. So they have no idea. I mean, now we're finding out that there's fentanyl in weed. So imagine that you have young ones, such as I do. My two youngest are 20 and 23 respectively. And let's say they partake in the sweet leaf, as Ozzy Osbourne would call it. Now imagine that, and in this state, it's legal recreationally. We'll talk about that. So my 23-year-old can do it legally. My 20-year-old, not quite until July 3rd, the day after UFO Day. Just imagine them experimenting with this, getting it from somebody, a source on the street that they don't know about, and it being contaminated with fentanyl. And now they die of respiratory depression or arrest because then they had no idea it was there. So a lot of this is because of adulteration and a lot of the drugs of abuse that are being used. And that's really the big thing nowadays, is that we don't know what's in anything. So I want to talk about alcohol just because it is legal. It's probably causes more morbidity and mortality than any other substance abuse out there. I can tell you it runs rampant in my family. But when we talk about kids, and now it's getting to be summer, and we're going to have margaritas and all kinds of daiquiris and that kind of stuff if you choose to do that. We just want you to be careful, because actually I worked last night, and we did have a kid was at a playground. Mom stated that he was at a playground in Minneapolis and drank something out of a cup. She had no idea what it was, but she said she thought it smelled like alcohol. Kid looked basically okay, maybe a little loopy. Obviously, that's very scary. Imagine if you're going to the park just to play and somebody left something out there and your kid drank it and you have no idea what it is. You call the poison center like this mom did. And I'm like, well, basically, if I don't know what it is, I can't help you. I'm not a prophet. I'm not a remote viewer, nothing like that. We need to know what it is so that we can competently give you information. the thing about this is that she did say it smelled like alcohol. So what I asked her is, hey, did you give your child anything to drink? And she said, yeah, I gave him apple juice. As many of you know, when children ingest alcohol, they can go ahead and get low blood sugars. And so that's our concern if somebody would take, a drink out of a daiquiri or something, or they drank a bunch of it while your back was turned and you were chatting with other people. They become drunken little sailors and they can, fall and get injury and trauma from that. But the biggest thing from a toxicological standpoint is we worry about low blood sugar. So if this does happen to happen at your gathering or your home or wherever you might be, just make sure that the first thing you should do is dilute your child with something sugary to make sure that the blood sugars don't plummet. One other thing too, another interesting drug of abuse that's considered to be legal and has been for eons since man's been alive basically, is nicotine. And I just want to take this opportunity to let you know that nicotine can be very, very dangerous in children. So as you see here, 12 milligrams of nicotine can cause serious illness or death within 60 to 90 minutes in children. So the old school way to do this would be, you come home, dad throws this pack of smokes on the table, little Billy, oh, look, candy sticks, and tries to eat one, spits it out, eats another one, spits it out. One entire cigarette has about the equivalent, and this ebbs and flows depending on, a bunch of different reasons, but by and large, most of them have about 12 milligrams in an entire stick or an entire cigarette. So if your child would ingest the entire one, they could have serious illness or possibly death from this pretty quickly. But most kids are pleasure seekers, right? Unless they have trisomy 21, they have a developmental disability, they're on the spectrum, that kind of stuff. Generally are not going to get into much because they're pleasure seekers. It goes in the mouth, it doesn't taste good, they spit it out. And so they're generally not going to eat an entire cigarette. But what they can do now is with this vape juice. So I've done a little quick math for you here. Basically 10 drops is the equivalent of 1 ml, and 5 ml equals 1 measured teaspoon. Okay, so not very much. So 1 ml of 3.6% of nicotine juice, which is by federal law supposed to be the highest they can put in. Of course, nobody's overseeing this, so they can put more in there, and they know that. But by law, what they're supposed to be able to put the maximum is 3.6%. That's the equivalent of 36 milligrams of nicotine in 10 drops of vape juice. That's how little it takes to go ahead and cause potential serious outcome in young children. And the first thing they're going to do is they're going to start being really hyper for about 15 to 20 minutes. And then the nicotine's going to go ahead and go down a different neurological pathway. And then they're going to have seizure, coma, and potentially death from this. So there again, obviously we don't encourage smoking or doing unhealthy things, but I mean, this is something that's legal. It's your right to go ahead and decide whether you want to go ahead and vape or not. But our impetus behind this is letting you know that this can be a dangerous substance and we should put this thing up high and out of sight or down low and locked up whenever possible. And that's the whole thread behind this is we need to take care of our children. If something's legal, it's legal. We're not getting down on you about that. We just want you to go ahead and know what things potentially can be more problematic for your children if they get into them. So if you don't remember anything else about this, nothing is what it seems when it comes to drugs of abuse. So I've been on a death scene before where a young lady who was addicted to Xanax, which is a benzodiazepine in the same family as Valium. She overdosed on that. And I went and she was, when I got there, her and her girlfriend were out partying. They stayed at the girlfriend's mom's apartment. They went to sleep, woke up, and the girlfriend tried to shake her friend awake and she wouldn't wake up and she was cold. So I got called there as the death scene investigator, went in, hey, what's going on? Did your friend have any addiction problems, substance abuse? She goes, yeah, she was addicted to Xanax. And I said, did she use more than usual last night? No. Did she drink more than usual last night? No. And so I had a DEA agent there who was there because this is when fentanyl was first being introduced. This is about probably 12 years ago, was being introduced into other drugs that weren't supposed to be there. And so we actually got the Xanax pill and then we looked at it and it looked pretty legit. And then the mom, the surviving pair came out and said, well, I'm on Xanax. I have one of those. And so we asked her to bring out hers and we put them side by side. And you could obviously see once you saw what the real one was, professionally produced at a pharmaceutical company, the difference in them. So the one that this gal had taken, we had tested and actually was contaminated with fentanyl. She had no idea about that. She didn't abuse opioids. She didn't want to. She knew what her drug of choice was, and that was Xanax. She knew what dosage it was, so she wouldn't get into trouble. but she bought them off the street thinking that they were real Xanax, and they had a little bit of Xanax in there, but they also alprazolam, but they also had a whole bunch of fentanyl in there. So unfortunately, this is where we need to educate, and this is where that number of youth is going up that are dying because they experiment, and we expect our youth to experiment. We try and tell them they shouldn't do drugs, and drugs are bad. And a lot of you that are my age remember the old frying pan. This is your brain on drugs, and they fry the egg kind of thing, scaring people. But I think just educating in different ways is really important to knowing your children. But this is one time your child doing something and trying something can result in their death because of contaminated things inside the medications that they're taking or the drugs of abuse. So this is what we were talking about: fentanyl-laced marijuana use in adolescence. So I can tell you that I've been on the scene just before I retired, where somebody was down. We got called to a scene. Hey, I go in the house. I was with my partner. One guy was down, one was up and freaking out. And I'm like, dude, what's going on? And he's like, yeah, we were smoking weed and my buddy went down. And I'm like, did the old look in his eyes thing and said, dude, you got to tell me what he really did or he's going to die kind of thing, to kind of scare him into giving me the information. He's like, no, dude, we just smoke weed. We don't like anything else. And so my partner's evaluating him. He indicates he's got pinpoint pupils, does this motion to me, which means, should I give him intranasal Narcan, which is the reversal agent for it? I said, yes. So he gave him the Narcan. I'm still talking to the other guy. And all of a sudden the guy would go up. He's like, what happened? Well, you overdosed, dude. And he's like, I just smoked weed, man. And it's like, well, obviously it had some fentanyl in it. People are putting fentanyl in weed. And his response was, dude, that's effed up. Why would people do that, man? We just want to get stoned. We don't want to die from it. And, legitimate question. And I can't answer that. I've tried talking with different people who are lower level drug dealers who get busted, from a medical standpoint and asking them why they do this. And a lot of it is because it gives it an extra kick. And if you're addicted to something, you get a tolerance to these different drugs and you don't really feel much other than withdrawal. And that's why you're taking them, is to prevent withdrawal. And so what was going on is, if your drug goes ahead and you're dealing a drug that has extra kick to it and gives you a little bit of something else, you're going to go over to that and you're going to tell yourself, yeah, I know a few people died from this dealer's stuff, but you know what? It's not going to be me, and it's never going to be you. And this is what's happening out there in the streets at every day. So we're going to cover some weed here. And I'm, number one, going to go ahead and make the disclaimer that I'm not a lawyer. I know a few of them, but I'm not a lawyer. I tried to get the latest information I could from your respective states that are part of this coalition. And so if this information is not the very latest that you know of, I apologize, and maybe you could correct me. But I think I'm pretty close on what most of your states are. So here in Minnesota, out of the 7 states that are in the coalition, we're the most quote unquote liberal with marijuana. We have medicinal marijuana, which we've had for a while, and we've enhanced that. We're actually going to be adding the flower smoking it, which previously we didn't have. I think we initially had like 9 different conditions that were eligible for medicinal marijuana. We're up to like almost 30 now. So we have medicinal marijuana in Minnesota, but we also have recreational marijuana. I can tell you that in the state, this has been a mess because we're the 23rd state to legalize, Minnesota that is, to legalize the edibles. And we didn't do very good planning because of the one side and the other side. One side just wanted to get it through, saw their opportunity, got it through, and they figured they'd fix all the legal things as they went. And so they've already had 2 different sessions. They're trying to fix this. We now have edibles that are legal in Minnesota, but by our law, we're only supposed to have 5 milligrams per gummy and not more than 10 gummies per packet. And the packet's not supposed to look like candy. So anybody that's from Minnesota listening to this, just laughs because you can go to the store. It may say 5 milligrams on there, but I can tell you there's nobody at the state level, the Department of Health level, watching the levels because those people haven't been hired yet. It won't be until at least 2025 in this state that we're going to have somebody who's going to be able to go to these people who are selling this legally, buy some of their stuff, test it to make sure that they're following the law. And so they all know that. And so they're putting more THC into their gummies because there again, if you're following the law and yours only has 5, but you go to the other store and they have 10 in there, hey, you're going to get higher off that. And that's what people are looking for. And so that's what we're experiencing here in Minnesota. I can tell you that we pride ourselves at the Minnesota Poison Control System, and all poison centers do, that one of our biggest functions is preventing needless emergency room visits. I can tell you that more than 90% of the time, and it varies from 90 to 91 to 92%, depending on the year. If we're called from the home setting about an exposure, we can safely keep that person at home. And if any of you guys are in EMS, work in an ER, work at a hospital, beds are at a premium, ERs are jam-packed. We're down EMS personnel. Police, fire, and EMS staffing is, you can just walk in and get a job with those areas as long as you're qualified. And so right now, we want to really try and keep people out. Last night when I worked, we had 6 cases, and a couple of these were adults, but a majority of them were children that had to go into an ER. And actually, one of them was still, I didn't look today and see if they're still inpatient, but this was a vape that a child got here in Minnesota, which is unusual because most of the time you have to have some hand-eye coordination. This kid was, I think, 2 or 3 years old. Took a hit off of it and wound up being absolutely gorped. And this happened yesterday somewhere before 2 o'clock. And when I called yesterday evening at 10 o'clock, the kid was still basically unresponsive, breathing okay, unresponsive, would wake up for periods, scream, eat something, and go back to sleep. Now, we kind of joke, well, maybe what'd you give the kid to eat? Funyuns, blah, blah, blah. But now we have kids that we're seeing, my whole impetus behind this is we're seeing an uptake in people going to the ER because we did not educate people about the dangers of edibles and the difference between smoking it and eating it and the availability to children. And we'll talk about more about that. So Iowa, basically, it's recreational is illegal. So they're pretty conservative and remain pretty conservative from a marijuana standpoint. And so if there's an update to that, please let me know. South Dakota is really interesting, and Corolla probably can fill us in better about this, but they've ebbed and flowed. They've sued, they've said it's unconstitutional. And as far as I can ascertain, recreational marijuana is still illegal technically. Even though it's been legalized, there's been a countersuit and a judge saying that it's unconstitutional. So I don't really know where they're at this point. I think at some point it's going to become recreational, it's going to become legal there, like totally without any kind of whatever, but I don't think we're quite there yet, or it's kind of quasi gray area right now. I don't think they're vigorously prosecuting people right now for that, but you can see here kind of the possession limit in South Dakota and that sort of thing. So North Dakota, there again, recreational marijuana is illegal as far as I know and as far as I read. Nebraska, it is illegal for recreational or medicinal use. So they're prohibited from cultivating the plant. So in Minnesota, the other thing is we can also grow, I think, up to 7 plants, but can't have more than 4 of them flowering at once. So here's as sad as this is, and really knowing what your state's laws are as much as you can. As you know, I've tried to find out what the laws are and what the current laws are in the states, and even then it's difficult to ascertain what they actually are. Most of the time, they're not vigorously prosecuting people. But it's gotten to the point in my state where if you can grow your own plants instead of buying it from somebody else and having it contaminated with fentanyl, it's like telling my 23-year-old, dude, if you're going to smoke weed, maybe you should just grow your own plants. Then you don't have to worry about fentanyl being put in there. And I can tell you as a father, I never thought those words would come out of my mouth. I never thought I'd be in a position where I have to say that, where my kids would be in danger. Obviously, the answer is, dude, don't smoke weed, right? It's legal. He's an adult. He does. And that's how it is. But for his safety, I'm going to go ahead and tell him to go ahead and grow his own. Now, not in my house, but he can grow his own. And then the other part, you can make it a science experiment, probably something not learning in school now. So they can go ahead and test the pH of the soil and maximize their yield. So, I make light of it. It's really not a light subject to me at all, but I have to kind of make light of it. And it is interesting that I've gotten to this point, and that a lot of us have gotten to this point with the marijuana laws. And keep in mind, marijuana is still a Schedule 1. At the federal level, there is still no medicinal use for it, which is interesting. And so the states are taking more control of it, and basically the feds are turning their head at it. I hear talk now that the Biden administration might go ahead and make marijuana Schedule 3. And so that's going to have some huge implications on everything, and probably even at the state level. So keep your eyes peeled. I mean, there's a lot of things that are said in the news that, it's an election year, so who knows? But I do suspect that at some point that it's going to be removed from Schedule 1 because it influences the way that you can make money, where you can keep your money from a legitimate state business that sells weed and weed products. So more to come on that. Kansas. So you can see here in Kansas, that little star is where my farm is. We're 90 minutes south of Kansas City. We have a family farm down there, and that's our newest little baby donkey down there. His name is Cayenne. We call him Kai. And so he was born about 3 weeks ago. I was a day late. I got there on Friday, and he was born on a Thursday. Thankfully, they're all okay. So all you guys that are in Kansas and Nebraska, hopefully you survived the storms, and pray for your safety down there. It's been pretty crazy spring. So Kansas there again, there's some things pending in their legislature this year. But as of now, you can use CBD, which is not hallucinogenic technically. But you can't use any products with THC as far as I know in the most recent information I could get. So what are in these things? So the weed that I might have partaken in when I graduated from Osseo Senior High in 1983 from that northwestern suburb in Minneapolis. If I wanted to get stoned, I would have went to the edge of the campus of high school, handed a $5 bill to the guy that looked like he had long stringy black hair, or a black leather jacket, and a Sony cassette Walkman because he's a drug dealer and could afford a Sony cassette Walkman, listening to Black Sabbath and Ozzy Osbourne as the lead singer. And he gave me actually the good stuff back in my day and gave me a nickel bag, $5 nickel bag, which is either Thai stick or Colombian gold. That was the good stuff back in my day. And so, you know, I get the good stuff. I smoke it. I laugh too hard at Scooby-Doo. I eat too many Totino's party pizzas. You know, the stuff that, oh, you laugh at stupid stuff and you get the munchies. But the THC content of the good stuff back then was about 2.5 to 5% THC content. Now, my two younger kids laugh at that and tell me, dude, we wouldn't even pay money for that stuff. But I mean, back then, that's what it was. So there again, we have not had the opportunity to do prospective double-blinded studies on marijuana specifically in this nation. They have done it in the Netherlands, but we have not been able to do that. And so everything that we're telling people is basically based on retrospective. And so we're testing this out basically on our populations. And really nobody had any significant morbidity and mortality from the stuff that, you know, I had available to me in 1983. Well, we're gonna find out that the plants now, the flowers that you can smoke, you can get up to 60% THC content. People are acting significantly different when they're smoking 60% THC as opposed to 5% THC. So your traditional THC is going to be what they call Delta 9, and that comes from the cannabis sativa plant. And so there's Delta 8, Delta 10, there's THCA, THCV. These are all just slight tweaks on the molecule, and they're all very, very closely related to THC or Delta 9. Now, for example, Delta 8 is called light weed. Light weed is supposedly, if you don't like the feeling of getting high from regular THC, this is for us old fogies like me, you know, we can take the Girl Scout version, so to speak, and take the Delta 8 and then, you know, feel a little bit high, but not to the point like Delta 9 would. And so they call it light weed. It's kind of like having a diet soda instead of I should say a zero sugar soda as opposed to a sugared soda kind of thing. That's kind of the analogy. Delta 10 is supposed to be more invigorating, so you don't sit on the couch as much, so that you're high but can still kind of function. And these other ones are basically just all variants on that. So you're not going to find any information except for what people theorize is happening because we've never done, the FDA has not approved these. They've not gone through, we don't know what their pharmacokinetics, their pharmacodynamics are. We don't know how long they last technically because they were never subjected to the 13 years of clinical or in the 4 stages of FDA clinical trials. So it's still a mystery. So here's CBD. So this is like we talked about earlier, CBD does not get you high directly. What it does though, there is some evidence, anecdotal evidence to say that basically that it can help with anti-inflammatory type things. It can help it maybe as an anti-seizure medication, those sorts of things. So having spent 9 years active military and 27 years in the fire service, I pretty much destroyed my body. I'm in constant daily pain, and it's manageable. I meditate, I do other things, you know, I try and do healthy things and exercise and all that. But, you know, I got to a point where one of my guys that I worked with, he no longer works at the Poison Center. He actually was a pharmacist for the state of Pennsylvania for their medicinal marijuana program. And this is, you know, I was still an active firefighter just under 2 years ago. And I went to him and I said, dude, I am not sleeping at night. I hurt. Can I take CBD? Will that show up in your analysis test? So going back a second, all those other Delta 8, 9, 10, all the THC, VOs, all that kind of stuff, they will show up positive in your analysis. And even if marijuana is legal in your state, it depends on your employer as to whether or not they can fire you for it. So just because it's legal doesn't mean that whatever job you're doing, that you can do it. You have to check with your employer. Okay. Now, CBD, I wanted something that was not going to alter me, that was not going to be illegal, was not going to be picked up on your analysis test, and this fit the bill. Now, what he told me is buy it from Charlotte's Web. And remember, I have no financial interest in this product at all. I bought it because he told me that this particular company who makes Charlotte's Web CBD it's high quality. It's not going to be adulterated with anything else. They actually ship out their stuff to an independent, well-known laboratory to make sure that there's no adulterants in it, such as, other THCs and that sort of thing. And so it's just straight CBD. It cost me about 119 bucks a month. I did it for a month. I put it under my tongue. It tastes horrible twice a day. And I could feel no perceivable difference in my pain levels and my joints and all that kind of stuff. So I wasn't going to pay another $119 for the next month. So I abandoned it. So I just telling you my experience with it, and it might help you. And this is something that's an alternative that is really does not psychoactive as long as you get the right stuff. But if you buy it from other places on the web, you don't know what you're going to get. So they can put anything they want into it despite what's on there, because when they sell it on the web, they're pretty much protected. They can just close down their website and hide. So I know some of you have seen this before, but when you smoke weed, right, you got that buddy growing up. I knew one guy who was a stoner, and he'd be just stoned all the time. And once in a while, he'd get some really good stuff, maybe that was, say, 7% THC content, took a big hit, and all of a sudden, like, dude, man, that was some good stuff. And it's like, oh my gosh, look, man, the aliens are coming to get me. It's like, dude, put the bong down, you're going to be fine. And then, a couple of minutes later, it crosses your blood-brain barrier when you smoke it pretty quick, and you can titrate your high when you smoke it. So after a couple of minutes, 15 to 30 minutes is its peak effects purportedly. He puts down the bong. He's like, dude, man, I freaked, didn't I? It's like, yep. He goes, man, that was some good stuff. I got to ease up on that. It's like, yeah. So they don't like to get noisy. They like to have that kind of buzz and feel floaty and that kind of stuff. And smoking too much of it can actually cause them to get paranoid. Now, when you ingest it, it's totally different. So think about this. Let's say you got a backache. You go ahead and you decide, well, I'm going to take a couple of Tylenol. So you take 2 Tylenol, 500 milligrams if you're an adult. You pop them. And so that goes for our digestive system. It doesn't immediately get into our bloodstream. It's going to take, 15 to 30 minutes for it to kick in, because we've got to swallow it. It's got to dissolve in our stomach. Then it's got to go through our hepatic vein, go through the liver, and then get to our central nervous system to hopefully try and relieve some of that pain that we're feeling. All right. It's the same thing with edibles. And I really, really, really wished that our Department of Health in Minnesota would have went ahead when they passed this legislation initially to make edibles and recreational marijuana legal, to put something about some basic education. Because when the government says something is safe, or not safe, but legal, that in essence, to a lot of lay people, that means that it's going to be safe. And so now they're like, people that were previously curious who wouldn't have ever smoked marijuana are going to like, hey, yeah, I'll try a little chunk of a chocolate bar and see if it makes me feel giddy. Even my mother-in-law, who's 72 years old, tried it, and she's like, oh yeah. And then one time she ate too much of one and she got paranoid. So here's the problem. Anybody who's out there in the audience who's worked in an ER or EMS knows that we see people come into the ER now because they're so paranoid, they feel like they're going to die. And I'm talking about, I look in their eyes and they're like, dude, man, I'm going to die. I feel like I'm going to die. And they are convinced that they're going to die. They have this feeling of impending doom, because what happens is, when you ingest a half of one of these, or one of these, let's say the recommended dose is 1. I always recommend cutting that recommended dose in half and taking that and waiting 2 hours before taking more. Because if you look, when you ingest it, it immediately turns into 11-hydroxyl THC, which is not THC anymore. It's much more psychoactive and can last hours, up to 24 hours sometimes, and you can't take it back like smoking and just putting down the bong after a couple minutes, okay? So now, just think about this, and it's going to take, anywhere from 30 to 90 minutes to kick in. So you take your half, and we're a pretty patient society, right? It's like, yeah, not at all. So you take your half, dude, it's been 30 minutes, and you're like, we'll take more. They wouldn't make it legal if it was, dangerous. So you take 4 or 5 more. Next thing you know, about 30 minutes later, you're like, oh my gosh, I'm going to die. You're paranoid. And everybody out there who's transported somebody like this or seen somebody in the ER knows exactly what I'm talking about. Now, here's the good news. From my experience, and as you've seen, I'm almost up to 100,000 cases now. I do this. This is what I do, and we take a lot of calls. I've never had an adult who smoked regular weed that wasn't adulterated with anything have serious illness or death acutely. Okay. So from that perspective, I think it's safe. But here's what they're doing. They're going to the ER and they're taking up valuable resources, and they don't really need to. All right. They feel like they need to, they actually don't. So what happens is when these people get so paranoid, they're like, they're not dangerous, they're not aggressive, but they're just really freaking out. And they're like, I'm going to die. Please help me. Please help me. And I mean, these people are really convinced that. It's like, dude, just relax. We're going to be in the hospital soon. They give them a couple milligrams of that, or a milligram of Ativan. They sit there for a couple of hours. They feel better, and then they feel embarrassed and they walk out. I recently talked to a friend of mine who I had no idea had this experience. She said that she couldn't speak properly for about 6 hours afterwards. I was actually at the Jay-Z Beyonce concert years ago when it was at the US Bank Center. And we had somebody come into our triage working EMS there. And it was a mid-50s-year-old couple. And the female was walking like a zombie and couldn't speak. And I'm like, dude, what's up with your significant other? Well, we had some edibles. I said, you ate too many, didn't you? Or she did. And he goes, yep, she did. She could not speak. I was like, hey, can you hear me? So immediately no. So I did squeeze my hands, raise your arms. But she couldn't speak. She couldn't speak for almost a couple of hours. And she didn't have anything wrong with her, but she just couldn't speak. And so my friend who told me about this, I'm like, oh my gosh, you know. So everybody that I've talked to, the females that have gotten too high in edibles, some of them have said that they're not able to speak properly or to speak at all. And I don't know what that's all about because we haven't studied it. And so just be careful with this stuff. Take it easy, wait 2 hours, take the lowest dose possible and half that. And part of the purpose of this is, the other purpose is if kids see this, they're going to see candy. And if you're sitting there on the couch kind of zoning out and Billy sees a bunch of candy there, they're going to go grab as much as they can because they know if you see them, they're going to say, no, put it down. And they're going to fill their mouth with it and they're going to be in the ER. And we know that kids now do have serious morbidity and possibly mortality, but at least serious morbidity has been described in the medical literature, and I've actually seen it. So these drinks, I can tell you now, I go to the liquor store to get some hard cider once in a while. They used to have lots of hard ciders. They don't have any hard ciders anymore. It's just one little corner. And I'm like, I asked the guy there, I'm like, dude, what's up? Why don't you have hard cider? Nobody wants it. They all want the THC drinks. So in Minnesota, THC drinks are legal. The max they can have in a drink is 10 milligrams in a drink. Recommended 5. A double shot is 10 milligrams. No alcohol in there. I have talked to people that have drank them. Some say they taste great, and some say they taste terrible. Just like beer, it's all personal preference. But here's what's interesting. In all the calls that I've taken about marijuana-related products, I have not had one person freak out about drinking multiple ones of these. I'm not saying it hasn't happened. I've talked to all my partners, like last night and the night before when I worked at the Poison Center. They have not either. So I don't know if it's the formulation of it. I don't know what it is, but we have not had, at least at our Poison Center, many people reporting many problems like freaking out or anything like that from drinking the drinks. So we just haven't had that experience. Doesn't mean that that's not anybody else's experience. So here's dabs. So this is called dabbing or waxing. Basically what you're doing is you are taking marijuana through a process, and I'll show you on the next slide what that process is, which is a dangerous process, and you're putting it into goo, and you're concentrating it up to almost 100% THC. And you heat it up, you put it on a hot bong, and you inhale the vapors once it hits that, and you get this purified THC. All right. People tend to freak out from this too. Now here's how it's made. You take butane. So for those of you who are not fire savvy, butane is very flammable. And you go ahead and you put your weed in this container and you put the butane through it, an average of 3 cylinders of it. The butane chemically pulls out all the THC out of the weed, and it drips underneath into a pan where it's being heated actively. So open butane, open heat flame, making this stuff called wax or dabs. You think there's any problem there? No, there is. So actually places have blown up from manufacturing these. A lot of people are taking over houses that have been abandoned, condemned, They will do that in there. One of the key giveaways is if you drive by and you see can upon can, just like thrown out the window of butane products outside, means that somebody's going ahead and cooking dabs in there. Now, they can explode. So one of my good friends is FDNY at the top of the Bronx on Engine 63. So he's a New York City firefighter. This was his battalion chief. He wasn't on shift when this gentleman died, when Chief Fahey died, but he was investigating one of these potential places. There's an odd smell coming from it. They're in an abandoned warehouse. The place exploded because an ignition source was, like just even opening a door, turning on a light, cueing a radio, that kind of stuff, exploded, and he died in that explosion because they were manufacturing wax and dabs in there. So now just making this marijuana product illegally can cause a hazardous situation and can cause people, neighbors, and that sort of thing to have serious problems from that. So let you know that that's out there. We're not seeing a lot of that anymore, but I just want to make you aware that it's out there because I've started seeing a couple more cases than I had, and things are cyclic. Everything goes in a cycle. So this is the other part of cannabinoids. This is K2 or spice. So this is what they call synthetic marijuana. So synthetic is not natural. This is made in a laboratory, and the chemical structures of this do not resemble marijuana at all. They do hit the CB1 and the CB2 receptors. That's the cannabinoid 1 and cannabinoid 2 receptors. So those of you who are unaware, we do have basically weed receptors in our body, and one does one and the other one does another thing. But they do go ahead and agonize those or cause action at that site. Actually, they cause full action of that, whereas when you're smoking regular weed, it doesn't cause full action of that receptor. But what's interesting about this is there's over 500 different independent chemical formulations for K2. Oh, probably about 11 years ago or so, they used to sell this over the counter because this was not identified as being illegal. This was nothing nobody had ever seen before, law enforcement in this nation, nothing. And so they could sell it until people started having problems. Excuse me. I can tell you that each individual strain out of those over 500 different chemical tweaks that there are, all do different things. It's not like just weed causing you to get like paranoid or drowsy or getting the munchies. Each one of these can do something different. So for example, one strain can cause low heart rate, low blood pressure, and cause you to die of hypoperfusion. Another strain can cause you to be tachycardic and seize, seize persistently. So they all do different things. Now, we used to see these in clusters, and this is the other strength of reporting things to poison centers is we actually identified 2 different clusters in Minneapolis and in St. Paul within a couple of weeks of each other. We got them tested. We were able to test one of them, but this is what's interesting. So there's over 500 different chemical formulations of the synthetic marijuana. We can still only test about 150 of them, which means that we can't convict people if people die using this stuff because we can't find it in their system because we can't test for it. And this is why they use these sorts of things. So there again, we're not seeing a lot of this. What was interesting though, 2 nights ago, I got a call from one of our large correctional facilities in our state. And she said, yeah, we had an inmate that said he used K2. And I'm like, what? How do you get K2 in the jail? Oh yeah, we got a lot of K2 here. Well, I think they just refer to it as that. I don't know that it's actually K2. And she says they just vomited persistently. Well, maybe that's what that one does. But they had skilled nursing facility there. And so they kept the guy there. But that's the first time I've heard about K2 in a little while. But here's the deal. Unbeknownst to you, if you report something to the poison center, we can start recognizing, like, overhearing my partner saying, hey, I got a K2 from, from the town where that jail is. Well, now we know there's probably a dealer there. And so we can alert our Department of Health and say, hey, we're seeing this cluster of, and we're not giving any demographics because we are HIPAA compliant, but we're saying we're seeing a cluster here. And in the interest of public safety, we can go ahead and maybe see if they can identify where it's coming from and see which strain it is and how dangerous it potentially could be. So that's why it's important to report everything to the poison center, even if you're a citizen. So here's kind of the history of synthetic marijuana. So as you can see here, it started back in 1964 as isolated, and then it really kind of hit up in about 2008, 2009 was being sold, and then they went ahead and legislated against it, basically stating that if you are selling something that's like this or similar to it, it's considered to be a novel synthetic drug and you can be prosecuted for it. The other thing, marijuana, is if you smoke a lot of it, particularly young males, in their late teens, early 20s that are chronic users of this, they can get something called cannabinoid hyperemesis syndrome. And I'm sure there's a couple of you out there who have seen this. This is not just vomiting a couple of times. This is cyclic vomiting for 24 hours. All right. And so I'll show you in the next slide kind of how this is purportedly working. But the other place that we see a lot of hyperemesis syndrome is in younger girls who are pregnant because they're smoking weed. And now they come in to their OB and they're like, they're puking. I mean, really puking a lot, which obviously losing fluids, getting dehydrated, and having electrolyte imbalances can be dangerous to yourself and the unborn child. But interestingly enough, they all want to take hot showers. Well, the idea behind that is getting hot water under their stomach, and we'll see why in a minute why that's important. But this is something that can happen. And here's the answer to how do you stop this? I was at a national or international tox meeting a couple of years ago, and the presenter who's the one that I use, whose slide I used here basically, said that, yeah, there's one way to get rid of this totally is to stop smoking weed. Of course, that's generally not an option, but one of my coworkers said that this happened to him and he just stopped smoking it because it happened to him once and he couldn't stop vomiting. If you are out there and you do happen to come across this and you're in the healthcare setting, giving them droperidol works. The other thing that we've used is capsaicin. So the hot pepper cream, if you put it on their stomach, that has been shown to go ahead and help them stop vomiting. So it's a pretty benign treatment. It's not going to do any harm other than it might cause their stomach to be a little irritated. But here's how it works. Basically, when you smoke a lot of cannabinoids, it stops, it inactivates this TRPV1 receptor. And this receptor stops making its chemical messenger. And then as a result, your stomach gets upset and starts vomiting. And so the way that it reactivates again is if you introduce heat. And where are those heat receptors? In the stomach area. So everybody knows if you start vomiting cyclically, if you in the kind of the pot community, so to speak, that you go and you take a hot shower. And this is why they want to take hot showers, is to get that heat on their stomach. And then in a certain percentage of the time, it will go ahead and reactivate, releasing that chemical messenger so that the cyclic vomiting stops. Same thing, kind of, putting the capsaicin cream. Capsaicin is basically hot pepper, putting that cream on your stomach. And then, so that's the reason that we're purportedly using that. So obviously from an EMS perspective, before doing that, you need to check with your medical direction, make sure your medical director is on board with it, but it's a pretty benign treatment. And I'm sure most of them would be, but this is the cyclic vomiting from using chronic marijuana. All right, let's get to the kids. So I put some studies in here. Usually my slides are a lot funner than this and not all wordy, but we have found, unlike the adults that I've said that I haven't seen any serious morbidity or mortality directly from THC or marijuana products, in children we have, okay? We have seen coma, respiratory depression, we've seen respiratory arrest, we've seen seizures, we've seen nausea and vomiting that's severe, bradycardia, hypotension, ataxia. I know of 5 kids that have been intubated from weed only. You say, well, maybe they got into something else. We tested their blood and their urine, and they only had weed in their systems. So obviously we know kids are not little adults. Their nervous systems are still being developed, but we've unleashed this substance and made it legal out there without testing it on children, which wouldn't be ethical anyway. I mean, there's a lot of things we don't test on children, but this just highlights more that we need to go ahead and educate people that this can be potentially dangerous to our young children, and to take good care of it, to lock it up, to make sure kids can't get into it. For all you guys listening here, to pass that on to your friends and your loved ones, your nieces, your nephews, your kids, your grandkids, all that kind of stuff. There again, we're not saying don't do it. If it's legal, it's totally within your right to do it. But just realize that in young children, usually in my experience, 4 or less, the 2 and 3-year-olds are most common, can have serious morbidity mortality from ingesting edibles. So, and they can be gorked for a long time and they get admitted to hospitals, and this is only weed. So just be aware of that. So, all right, getting back to some other opioids. So interestingly enough, Bayer, kind of a familiar name, right? In the pharmaceutical industry, came out with heroin. It was supposed to be the non-addictive morphine substitute back in the late 1800s, early 1900s. How laughable is that, right? We all know that obviously that's not the case. But so interestingly enough, maybe some of you guys didn't know this about me. My mom was a nurse at Minneapolis Children's. When I was 2 years old, I ate children's chewable aspirin because we didn't have Tylenol back then for you youngins, and we all didn't die of Reye syndrome. And I drank bleach. So, and I got my stomach pumped both times for that. So I guess I have a special place in my heart for Bear aspirin because the orange chewables do actually taste like candy. So anyway, so this is just how we've evolved, even within, just a century and a quarter. So here's some other things. This is from the National Survey on Drug Use and Health. So these are drug surveys that were sent out to people, to teens and adults. So there again, I'm not trying to say it's a gateway drug. Some people say it is, some say it isn't, some say it is potentially. I think a lot of it depends on your own personal chemistry and your exposure to it. So for example, my father-in-law, who now is full-blown dementia, but he had been an addict for, alcohol and pills. And he was sober for, when I talked to him about this, for over 20 years. And I asked him one day, I'm like, Gary, do you ever miss drinking or using the Percocets? And he said, every single day. I'm like, every day for 20 some years? And he said, yeah. He says, think about it like this. He says, think about a cylinder of rubber, and you twist it an opposite way. What's it want to do when you twist it? It's under stress and it wants to go back to its regular position, to homeostasis, right? To a normalcy. He said this to me, every day that I'm not using for these 20 some years, I felt abnormal and I felt twisted. Folks, I can tell you what, if I felt abnormal and twisted for over 20 years by not using something, I don't think I would have been mentally strong enough not to use it. He was, and I have an immense amount of respect for that man, for being able to get clean, and anybody who can get clean from drugs, because coming from my, suburban upbringing, I wasn't exposed to much of this. And if you're doing something that's dumb, just stop, because if you're losing your kids, your job, and it's ruining your life, just stop it. After I've talked to people like this over the last 15 years, the second half of my career, these people, I've had one guy tell me, do you think I want to be like this? And I'm like, well, no. And he says, it is incredibly difficult to get off this stuff. So the whole key is trying not to even start this stuff. And my other point is that I think my father-in-law is wired a little different than me. I can have one or two drinks and be fine and walk away from it. My brother, he has one drink. He can't stop until he's in detox pissing himself. He realized that early on, and he never went through treatment. He just quit drinking. But my father, he left my family when I was 5 because he chose alcohol over the family. He got sober too. But my point is that we're all wired a little differently, and, don't tempt it if you don't need to. So, all right. So, I guess this is where I'm supposed to say I blew this again, the poll. So the poll is basically true or false that there's actually opioids that are resistant to Narcan. So as George Tsoukalos says here, nah, they're not. Part of my job, having my foot in both the clinical side of things and in EMS, is to go ahead and dispel myths and act as a bridge between inpatient and pre-hospital. Okay. See there, look at that. And you even saw the answer. So this is good. So this is going to be a good point for us here. All right. So the reason behind this is because it's adulterated with something. So you guys might have remembered when heroin came out, right? Heroin was around for a long time. Then it got contaminated with fentanyl. Now fentanyl is contaminating a whole bunch of stuff. Now fentanyl is being contaminated with xylazine. Some fentanyl used to be contaminated with carfentanil, which is 100 times more potent than fentanyl, which is already potent. And carfentanil was a veterinary drug used to put down elephants so they could do medical procedures on them. That's pretty much gone by the wayside. Now they're contaminating with xylazine. So imagine this. You have opiate use disorder. You have to get your opiates a couple of times a day, otherwise you go into withdrawal. All right. So you buy your fentanyl, because there's not much heroin. They still call it heroin out of reflex, some of them, because they've been around a while and been addicted that long. There's no real heroin out there by and large. And we'll talk about why that is in a minute. But there's no heroin, so they put fentanyl in there. They go get their fentanyl, and now they're worried about, is their fentanyl even really fentanyl? Could there be something else like xylazine in there? So we're seeing that a lot of xylazine, and in this particular study right here, we're seeing more and more xylazine in Minnesota being contaminating fentanyl. Now, xylazine is not an opioid. So imagine you come up, yeah, my friend did fentanyl. You give them the Narcan up their nose, or you give, if you're a medic, you go ahead and you give them IV or IM, and they don't wake up. So what else are you going to think? Yep, this must be an opioid that is Narcan resistant, because that's that's typical thinking. It's not. There's actually another component in there that's not being reported because nobody's controlling it. It's an illegal drug trade. And they're putting something in there that's not an opioid. So we're seeing a lot of xylazine in there. Xylazine can cause low heart rate, low blood pressure, which generally most opiates can, but generally doesn't. And it can last 12 to 24 hours. It can cause cardiac arrest. It can cause lesions peripherally, not from opportunistic disease from using needles as a direct mechanism. This is a drug that's used in big animals again, but it's not an opiate. It's used for like if they work on wisdom teeth. It's kind of like it's a hypnotic sedative for large animals is what xylazine is. It's not approved for human use. So what it's called tranq or zombie heroin. And so people that have opiate use disorder, there again, they've already got enough problems because they're addicted. And it's probably ruined their lives. And now they got to worry about wondering if their fentanyl is even pure enough for them to use. So what a horrible place to be, right? I mean, now you're addicted, which you don't want to be. And now you got to worry about you getting dope sick. You got to go buy from somebody that maybe now, because your dealer got arrested, you got to go to a different dealer you're not familiar with. And maybe they got stuff in there that you don't know about. And now you wake up in the ER intubated because it had xylazine in it and you didn't know that. So this is the world that we live in. Nothing is what it seems. Here's more pills. These are being pressed in garages, being pressed in warehouses. This is not hard to do, folks. The one on the left is legitimate. These are, if you look up what M in a square with 30 is on Dr. Google, it'll tell you it's 30 milligrams of oxycodone. The ones on the right are pills that were pressed in a garage and sold with fentanyl, carfentanil, xylazine. They found methamphetamines in there, cocaine, and any combination thereof. So I've had people that have had opiate use disorder, been addicted to opiates for a couple of decades, and their tolerance is very high. So they don't get high very much anymore. They're taking it to prevent getting dope sick. And so what's happening is they'll take a half one of these and they'll go unresponsive because it's so potent, and then get woken up and go, and I've been up bedside and asked them, hey, what'd you take? I took one of those M30s. They never should have done that. It must have been one of those counterfeit ones, because a half of a 30 milligram oxycodone is not going to do that to a 20-year opiate use disorder person. And so it's got something else in it. Sometimes we can test them, sometimes we can't. But that's the challenge. I mean, in EMS and in the ERs, we were used to going ahead and saying, oh, it's fentanyl. We'll just give them Narcan, wake them up, see if they want treatment, and hopefully they can get better. Nowadays, give them Narcan, it doesn't work. Then you got to go, oh, crap. If you're BLS, you don't have the ability to intubate, that can be a problem for you. Now you have to wait for ALS to come, and so they can intubate, so they can breathe for you until we can figure out what this is. So nothing is what it seems. So when's the last time we actually had a heroin epidemic? A little history here. My uncle was a combat vet from Vietnam. He said that the drugs were rampant there, obviously, because they were horrible conditions, especially towards the end of the war. They estimate that 10 to 20% of the U.S. soldiers were addicted to opium or heroin. Okay. So here's how they dealt with it then. And I'm not saying this is how we should deal with it, but I'm just showing here that we had a problem one time in history. And I think we're no longer good students of history anymore, because history repeats itself. I think if you're a good student of history, you can be more accurate than any psychic or any remote viewer that I know. But anyway, so when you're coming to the end of your tour in Vietnam, which was usually 12 months if you're in the Army, you went to wherever, get processed out a couple of weeks ahead of time. You had to give a urine sample. If your urine sample was positive for opiates, you didn't get to go home. And so what they did is they went ahead and they put you into detox for 5 to 7 days. What do you think that detox entailed? I've been trying to look in the historical data, and I've been digging this. And if I happen to be, I'm just a 2-year RN, so I've only got an associate's degree. But if I did a master's project or a PhD, I'd do it on something like this because I find this interesting. I think what they actually did, and I can't prove this yet, I'm still looking, is that they put them in a room and they let them detox and withdraw on their own without treatment. So horrible, absolutely. But withdrawal from opioids generally is not life-threatening. It is absolutely just horrible. And people will tell you that have opiate use disorder, they would rather die than go through withdrawal. But this is how they did it. Now look at the success rates. So 10 to 20% of all the troops over there is tens of thousands of troops, right? And so after a year, only 1% of them remained addicted after going through this detox, okay? So obviously not the most huggy-feely type of detox, if I'm suspecting what it is, but I'm pretty sure that's what it is. and only 5 relapse within a year. So that's pretty good numbers, way better than numbers we're getting from treating with methadone or Suboxone. There again, I'm not advocating for this. I'm just simply throwing this out and showing you an example in history of how there was an opiate epidemic and how it was dealt with. So why do they use fentanyl instead of heroin now? It's all about the Benjamins. If you want to buy a kilo of heroin, which is 2.2 pounds, it's going to run you about $35,000. Now, like gold or copper, it's going to change a couple $100 day to day, but generally it's going to run you for $35,000. If you can buy $35,000, if you can go have $35,000 laying around, you buy 2.2 pounds of heroin, you step on it, which is the term for cutting it down to make it least potent so that you can maximize your profits when you sell it. You can make about $125,000 to $200,000. Pretty good, right? Better than Edward Jones is going to get you for your investments or your 401k kind of thing. The problem is that dealing this is dangerous. Now, and if you talk to anybody who's had heroin and fentanyl, they're all going to tell you that heroin is a way better high. But so what happens is they get you addicted to the heroin and then they switch you over to fentanyl. Why did they do that? Because 2.2 pounds of fentanyl is only going to run you about $3,500. And it's going to go ahead and net you the same $125,000 to $200,000 in the end. So imagine that you're using, you get the heroin, which people that I've talked to have used it within the first couple of weeks said it's the best thing they've ever experienced in their life. Okay. But as you use it more, you get high less and less, and you get more, you take it more to prevent the withdrawal effects. All right. So now they switch you to fentanyl. So you go to your dealer and like, hey, dude, your stuff sucks, man. I'm paying you good money and you're giving me crap. You think a drug dealer is going to, take well to that? No, it's going to be like this. Bam, bam, GSW to the chest. And now, fun for EMS to handle in the emergency room, but not so much fun for the user. So you go there and you're like, hey, dude, that stuff wasn't so great last time. You got anything better? Got what you got, So you buy it because you don't want to get dope sick and you just continue down that road. And so if you hear about somebody else's that's given an extra kick, that's why you go to the next dealer down the line. You don't think you're going to be the one that's going to die because it's got something else in it that you don't know about. And it's like, it's literally drug roulette for that. So it's just a never ending cycle. So here's fentanyl pops. I don't know if anybody have ever seen these. If you're in the military, you have. One of my buddies, he got shot in the side with an AK-47. He got medevaced with the PJs. He told me they put one of these in his mouth and he said all the pain went away. And then after a while, and they're getting ready to land, he said he started feeling the pain. They gave him another one. Then they tried to take it when they landed. He told me he wouldn't let him take it. So he says, you'll have to kill me first. So it works very well for what it's designed for. All right. I actually had a kid. I got a call from an ER that said that this 2-year-old kid was unresponsive, pinpoint pupils. And I said, well, did you try Narcan? Well, why'd we do that? He was with his mom. He was at the doctor's office. And I'm like, okay, well, what's the downside to giving a kid Narcan? Nothing. Why don't you try it? They gave it to him. He woke up. And it's like, oh. So I said, he's at the doctor's office. What happened? Oh, well, they kind of described what happened. And what wound up happening was there's another person in the doctor's office who had one of these fentanyl suckers in her purse. The kid saw this gal sucking on it, putting it back in her purse. He crawled over there, and while she was on her phone distracted, he went ahead and put it in his mouth and sucked on it and then went unresponsive. So we determined this after the fact. But this was a kid, so he had fentanyl poisoning, opiate poisoning. So we gave him Narcan, which there was no downside to doing. Nobody thought about doing that because it wasn't part of the history, kind of thing. The other thing, touching fentanyl is not going to cause you to absorb it through your skin and die. It just doesn't. It does not absorb well through the skin. That is another myth that has been totally debunked. So somebody even as high as the number 2 person in the FBI has basically said that that's the case, and it actually is not. He was not speaking out of it. He was not a medical expert and did not know how fentanyl went. He was just parroting something that somebody told him, and it was unsubstantiated. Now, there are patches you can put on, and they're meant to go ahead and absorb for 12 to 24 hours. But what they're doing is they're pushing medication until it reaches an equilibrium. So actually, when you pull the used patch off after 24 hours, there's still 40 to 60% of fentanyl in that patch. And if you cut them up in 4s and go out in the street, you can make $80, $20 per quarter strip of the used fentanyl patch because people will buy them. There's just a little somebody else's skin on there, no big deal. And they'll put it between their cheek and gum and they'll get a good high off of it. So if you want to make some money, keep those used fentanyl patches. This is why we say flush them down the toilet. And of course, people get worked up about that because, oh, we're going to contaminate the water supply. But if you just put them in the garbage and people are in the know, they'll take them out, put them in their pocket, and they'll sell them on the street. All right. So how potent is fentanyl? I was an expert witness for the Hennepin prosecutor's office at one point in time. This was my first case. This was a gentleman who had 7.44, got busted with 7.44 pounds of pure fentanyl. Okay. Now that's about the size of a obese Chihuahua, right? Not very much. I mean, 7.44 pounds, but you could easily curl that for, all day long kind of thing. So what I did is I figured out how many milligrams that was, 3.3 milligrams, 3.3 million milligrams of fentanyl. And so post-operative pain, I actually just had some major surgery, which I'm still recovering from. And post-operatively, I was looking at the surgical summary, and I actually got post-operatively when I was in the PACU, I got 0.3 twice, which is, I was supposed to have procedural sedation, but actually they had to switch over and intubate me just before the procedure because I wasn't tolerating conscious sedation. So anyway, they used it to sedate me, and that was an acceptable amount, 0.3. But if you look at post-op pain at 0.12 milligrams, that's 28 million doses with 7.44 pounds. Procedural sedation, 0.3 milligrams. That's your colonoscopy, endoscopy, your wisdom teeth removal if you're not putting you under kind of thing. That's 11.2 million doses. And the lethal dose for people that are not addicted to opioids is 2 milligrams. And that, for 7.44 pounds, if it was delivered to every man, woman, and child in Minneapolis and St. Paul proper, would have killed every single one of them. That's how potent fentanyl is, okay? Now imagine carfentanil, which is 100 times more potent. So we're talking very, very potent stuff here, okay? So here's some more. This is Centers for Disease Control data. We are seeing fentanyl in teen deaths. There again, the fentanyl is being adulterated or being put into stuff that they're not used to. Weed, other things that that are put into other medications and stuff that they're experimenting with. They don't know it, and they die of respiratory arrest. Toddlers, there again, if there's more fentanyl out there, more people are going to be exposed to it. And this is just the Minnesota Poison Control System's experience with it since 2002. And actually, this doesn't even include latter 2023 data, but 66 exposures in kids under the age of 3 since 2022 up until 2023. So this is generally how it works. Some of you have seen this before too. I kind of changed it up a little bit. So there's me. I'm the opioid receptor called the mu receptor in the central nervous system. So when I was in pain post-surgically, they gave me the heroin or the fentanyl, which is my wife, and I gave her a hug. And after almost 29 years of marriage, she's still kind of my heroin or my fentanyl and feels pretty good. But if Nicole Kidman enters the room and she gives me permission to hug her, I'm going to always choose Nicole Kidman over my wife. I might get divorced, but you know what? Hey, I got to hug Nicole Kidman with her permission. So my point is that when we give Narcan, which is a reversal agent for opioids, in the presence of Nicole Kidman or Narcan or my wife, I am always going to choose Nicole Kidman. So if you give me Narcan and there's an opiate on board, it's going to kick it off and it's going to make me go, what happened? You overdosed. No, I didn't. That's what they say more than 90% of the time. Some of you out there can appreciate that. And some of you have no idea that happens. But that's what they do more than 90% of the time. I was fine. Yeah, you were just about dead, dude. That's why we're here. I don't know you from Adam. Why would I be here with the cops and the paramedics and all that kind of stuff? So now we have Narcan. This is universally the reversal agent. Now, it doesn't cure anything. It just bumps off the opioid off that receptor so that you can wake up and breathe again. Here's the problem. 4 milligrams intranasal up the nose is the equivalent of 2.1 milligrams IV. So it's about half, just over half the strength of giving it IV directly, okay? Now, I know a lot of BLS agents, and in Minnesota, all law enforcement, it's a state law that all law enforcement have to carry 2 4 milligram intranasal apparatus with them at all times. That's Minnesota state law. Most BLS do have this, but some are electing not to use it. But here's the problem. If somebody's unresponsive from an opiate, some opiates require more Narcan than others. So for example, heroin, they've done studies on that and found that 0.2 milligrams will go ahead and bump off my wife from the receptor and allow me to hug Nicole Kidman, okay? That's pretty low. Now, when you give somebody the equivalent of 2.1 milligrams IV or 4 milligrams intranasal, what do you do when you give them that? Because we can't titrate this. We have to give that full amount up the nostril. Okay. They wake up and they go into withdrawal. Now remember, withdrawal is not life-threatening, but they don't like it. And so a lot of these people sometimes, be warned, and in my state, Minnesota, and I'm sure a lot of states are like this probably, that you can get this free of charge, or pay a small amount to have it. You can have Narcan. A pharmacist in Minnesota can write you a prescription to get it, because if you give it to somebody they don't need it, it's not going to hurt them. So you can give it to them. They fall down. You give it to them. And if you give somebody Narcan, like you're at the bus stop, the rare times that I work a day shift in downtown Minneapolis, I ride public transportation. If I'm there long enough, I'll see somebody go down from usually fentanyl and all their friends who are homeless running over there because they have all of their Narcan, shoving it up their nose and waking them up and saving their life. But the problem is that they wake up and they start swearing at you and they're pissed off because you put them to withdrawal. And they will call your mom interesting things that I've never. Now remember, I spent 9 years as a drunken sailor, and so I can swear pretty good. But these people put me to shame. That's because they feel terrible. Don't take it personally. They generally, in my experience, do not get violent with you. And they usually do pretty well. They just let it blow by you. They'll call you all kinds of stuff, but they're generally not violent, has been my experience. All right, so how long do we observe these people? So let's say you came in, you picked up somebody, or you had a loved one who was unresponsive from doing fentanyl. You gave them Narcan, whether you did at home as the loved one, or whether EMS did it for you. They woke up, they go to the emergency room. General standard of care is we watch them for 4 hours. If they don't need any more Narcan, we let them go. Okay. The exceptions to that would be OxyContin, which are longer acting, or methadone. Okay. So here's what we're using to treat people with opiate use disorder. We're using a lot of methadone in the United States. Now, methadone is not the optimal thing to use. Actually, Suboxone or buprenorphine is what's been used in Europe for a long time with lots of success. What's great about Suboxone is that it's got a sealing effect. Methadone, if you take enough of it, you can actually stop breathing. So if you don't take the dose that you're used to, you can stop breathing. Or if you give the dose that you take to somebody who is not on opiates, they can stop breathing. Okay. Suboxone or buprenorphine is not like that. If you reach 16 milligrams, it will not cause any more CNS or respiratory depression at all. So from that perspective, it's safe. It's safe in pregnancy. It's easier to access for doctors to prescribe it. As a matter of fact, at Hennepin Healthcare, otherwise known as HCMC, which is one of the 2 level 1 trauma centers in Minneapolis, our EMS is one of 3 EMS systems in the United States that actually give this in the field under strict guidelines. So now we're not waking them up and getting them pissed off in the back of our rig. We're giving this to them under certain conditions, and now they just kind of wake up, but we didn't put them into withdrawal. And now they're much nicer about it. They're more amenable to getting help. We're also using it in our ER at Hennepin. So this is going to be an emerging treatment modality for those of you in EMS and in the healthcare setting. So you can't get your opioids. What do? You feel that gnawing in your stomach because you know that your drug sickness is coming, your dope sickness is coming. So you can try kratom. The internet says that kratom is a plant, it's natural, and it's a good alternative to go ahead and like hug my wife, hug that mu receptor so that you don't have withdrawal effects. All that's true. The problem is that when I get a call from doctors or I'm on the scene where somebody's having a seizure and I get the history, it's like, hey, what happened? Well, I used to be on opiates. Then I switched over to kratom to get off the opiates. And then I stopped kratom 2 days ago. Oh, you can't do that. Well, what do you mean? It's natural. We have found there again, no studies, not FDA approved. This has been our experience time after time, is that kratom will go ahead and act as a substitute for opiates. And it is totally natural. The problem is that when you're using it and you suddenly stop and don't taper off, is it does cause withdrawal seizures, which opiates don't. So actually, in essence, from stopping this is more dangerous than opiates even from a withdrawal perspective. It can cause seizures. So I had a doctor once say, well, he told me the same thing. Guy stopped 3 days ago. He comes in seizing. He can't stop seizing. What do I do? He used kratom and he stopped using it. I said, he's got to start using it again. Well, I can't tell him that. I said, well, that's what he needs. Either that or give him some ketamine, or some, not ketamine, some fentanyl. He's like, well, I can't do that either. It's like, well, this is where we're stuck as clinicians and that kind of stuff is. So what he really needs to do is go ahead and go back to whatever he was using before when he stopped. and then half that each week, which is generally what we do with other things that people are addicted to with regular prescription meds. Gabapentin. So this is really, really safe. It does not hug that mu receptor, but people that I've talked to that are in withdrawal say it takes the edge off so that they can go find their opiate somewhere else. So let's say now it's been an hour, they're on the verge of full-blown withdrawal, they're going to get sick, get diarrhea, have their hair stand up on end, their stomach is just knotted up, and they know that they need to get somewhere, and it's going to be another hour. They take a bunch of gabapentin. I mean, like 10 grams, 20 grams, yes, grams, 10,000 to 20,000 milligrams to get them by. The good news is that much gabapentin doesn't generally cause anything else than minor CNS depression. Okay, so that's another option. Tramadol. Tramadol is opiate-like. Tramadol is a Schedule 5, least potential to go ahead and be addicted to. Here again, here's the problem. Let's say you're post-surgery, you had a knee replaced. They don't want to give you too many opioids because they don't want you to get addicted because of all the lawsuits and that kind of stuff. So they give you tramadol because the doctors read up that, oh, tramadol is a Schedule 5, not a Schedule 2, so it's unlikely to get addicted. But anybody who's used opiates before knows that this will go ahead and hug that mu receptor, but it's going to take a little more because now you have a tolerance built up to it. And so what's going to happen is you're going to take the tramadol, you're going to take a bunch of them at once just to go ahead and get that feeling. And unfortunately, it does a couple of other things. You get serotonin syndrome from it. So if you're on other medications that are serotonergic, like Paxil, Zoloft, Celexa, Lexapro, Trazodone, those sorts of things, and you take a bunch of this, you can get something called serotonin syndrome that can be life-threatening. Seizures, high body temperature, those sorts of things. Also, it can cause seizures in and of itself. And so, and it doesn't work so on people. It's highly variable. Like some of you probably have used codeine. Each one of us metabolize codeine in a different way. Some are fast acetylators, some are slow acetylators. So some people works good on, some people it doesn't. So tramadol is not a good answer just because it's less addictive. It's actually more dangerous in overdose than the opiate itself, because you can wake them up with Narcan, but now you can't stop the seizure. You have to give them another medication called a benzodiazepine to stop the seizure. So that's kind of opiates in a nutshell. That's by and large what we're seeing now, or something, what they think is an opiate that's being adulterated with something. Other agents that people use. So we see a lot of teenage kids that go ahead and abuse diphenhydramine. This is what we call an anticholinergic agent. They also do the nutmeg challenge. Okay, so nutmeg is natural. If you take enough nutmeg, you can go ahead and see pretty pink elephants. The problem is it's also going to cause you not to be able to urinate and have to go to a hospital and have Nurse Kirk go ahead and cath you and not have such a fun day. So here's what these agents do. If you see a Benadryl overdose, their skin is going to do three things. It's going to be dry as a bone. Their mouth's going to be dry. Their mucosal membranes are going to be dry. Their skin's going to be dry. Their skin's going to be red and flushed, and it's going to feel hot. Now, they're not going to have a fever, but it's going to feel hot. Their pupils are going to be huge. They're going to be dry as a bone, red as a beet, hot as a hare, blind as a bat, mad as a hatter. They're going to have some altered mental status. They're going to be picking, like, it looks like they're picking cherries off a tree, or they're talking nonsensically to people who are not there, to their secret secret friend. They're also going to get full as a flask. They're going to get urinary retention. Okay, this is very important for those of you that are in the clinical setting, not to miss this, because sometimes we give them but when they're agitated, we give them a whole bunch of Ativan to calm them down, a sedative, and we give them like 5 milligrams, which, to those of you that don't know, that's a lot for somebody who, they should be very sedated after 5 milligrams of Ativan, but they're still agitated. Well, have you checked their bladder? No. I've had one person almost 1.5 liters out of their bladder. It was on the verge of bursting. So they need to be cathed. And then they get tacky as a polyester suit. This is another one that's very common amongst teens, especially 14, 15-year-olds, because this is not generally behind the counter. It's not mandated like pseudoephedrine is. It's Robitussin DM. It's called robo-tripping. And so what you do is you drink a whole bottle of this, and actually between you, me, and the wall, you just basically get drunk. And you do stupid things. You get instead of liquid courage, you get Robitussin courage. And you do dumb things, and you wind up coming in secondary, getting trauma secondary to having robo courage kind of stuff. It's actually pretty well tolerated. And between you, me, and the wall, it's much safer to do than doing the Benadryl if you want to get high as a teen or a tween. Obviously not advocating it, but it is the safer. Now, they also say do Coricidin, HPP, cough, and cold. The reason behind this is because these have a source. They also call it skittling because those little red pills look like Skittles, or triple C's, because on these pills, it'll say C and then C plus C. So that's Coricidin, cough plus cold. That's what that stands for. So they call it triple C's or skittling. And they will take a box of this. The problem is that there's also an antihistamine in there, which is like diphenhydramine, that will cause them to have the urinary retention, the other things, in addition to being drunk. So that's actually more dangerous than doing either one of them, is having both of them in there. LSD, guess what, folks? For you guys that are my age and even older, there's no more LSD out there, lysergic acid. What they're selling is LSD nowadays. My 20-year-old, she is, everything's cyclic. She likes the hippie stuff. She's got the bag, the brightly colored bag with the peace sign on it. She wants to drive a VW Bug. That's her dream, is to have one of those and go camping all over the place, that kind of stuff. And the whole culture is kind of appealing and come back around. The problem is that LSD on the street is not lysergic acid anymore. It is a hallucinogenic amphetamine that's basically the equivalent of a bath salt. So here's a young lady. She was 17 years old in 2014 in Minnesota. She thought she was taking LSD to trip, and she actually wound up dying because it was a hallucinogenic amphetamine, and she basically died of a cardiac arrest. There again, things are not what they seem. They can even come on this colorful piece of paper. If you look very closely, has little dots on it. You tear off just a little piece of that, and you put it under your tongue, you go flying off into whatever. That's how acid used to work. They're putting now the hallucinogenic amphetamine, 1 drop in each one of these things, so that it looks the same. The delivery is the same. They call it the same thing, but the people distributing know it's different, and it's much more dangerous than the acid was. And toad licking. Hey, you guys may have heard about this. You may not have. If you saw if you're a Simpsons fan, you saw when he was on the island and he licked the different toads. Like, nope, woo! Saw the pretty pink elephants. So this is actually a thing. They're looking for the Colorado River cane toad, or the Colorado River toad, or the cane toad down in Florida. And these are what they call the bufu species, and they do secrete a toxin that's actually similar to digoxin. So many people were catching these frogs in Denver area and milking them for their venom that they'd now become endangered. Now their DNR actually puts out instructions on how to properly milk them without harming the toad, interestingly enough, so that the toad can live and not become endangered, and they can go ahead and get high from their venom. So don't ask me. Some people will buy the skins of these toads online and soak them in a tea and drink it. I eat bugs, but I'm not going to drink toad skin tea. Sorry. All right. So with that, that's all I have for you. I'm going to turn it over to Mandy from here on out. So I will stop sharing. Mandy, I'll let you pick it up.
Thank you, Kirk. Really appreciate it. And thank you to the EMSC folks for inviting us to speak. Kjelsey, I'm going to have you go ahead and launch the poll for me. I'm going to be talking about awareness, education, and prevention. So how many of you have ever called the Poison Center before? Doesn't matter if you've called it for your child or for work, just if you've called the Poison Center at all. Just curious, how many of you have called the Poison Center? Okay, it looks like about 64% have called the Poison Center. Not sure if you're aware, there was a report that came out in 2012. It was done by the Lewin Group, which reported on the value of US poison centers. And they shared that for every dollar invested in a US poison center, $13.39 were saved in medical costs. I'm not sure why my slides are not advancing.
I think if you just hit your arrow button on the
Yep, there it goes. All right. So we're going to talk about the why behind the risk factors for poisoning. So risk factors for unintentional poisonings where children play a passive role are due to the actions of caregivers. So they're incorrectly dosing a medicine for an infant, and then there's the other unintentional role where a child or a toddler is actively involved in their self-poisoning. So now we're going to look at some developmental factors, the normal developmental progression of young children, including exploration of their environment, places them at risk for poisoning. Young children place objects in their mouth to taste. It's a way that they learn and explore their world. As the kids get older, they're a toddler now, and their motor skills improve. They may be able to open a bottle top, or may be able to open something that you didn't think they would. So just remembering that children like to mimic adults, so it's important not to take medicine in front of them or open things in front of them, because they may want to open things like bottles to be helpful. Okay, looking at some environmental factors, some things that people may not realize, that everyday items could be stored in lower cabinets for easy access for the child. There may also be the potential that a caregiver may not realize that products are poison. We always say at the Poison Center, the dose makes the poison. Medicines or products being left out just for a moment. As we know, kids act quick. And then the products also looking, as you can see in the picture, like something good to eat or drink. The windshield washer fluid looking like the sports drink or the juice in the fridge. I remember when my sister was probably about 4 and this story was told to me. She's younger than I am. She was at daycare. There was children's acetaminophen up on the entertainment center. The daycare son's, he climbed up and got it. They got it open. My sister ate some. She ended up going to the ER and getting some activated charcoal. Thankfully, she didn't have any effects or liver damage from it. Now I'm going to have you launch another poll, Kjelsey. Okay. Where do you think most poisonings happen? Home, school, or work? Okay, yeah, everyone knows the answer. They happen at home. Yep. So 90% of all poisonings happen at home because, of course, that's where people spend most of their time. And you may think, why am I talking a lot about kids under 6? Because in 2023, 35% of our poisoning calls were for children under 6. It's never too early to start talking about poison prevention. As I mentioned before, infants or babies, their poisoning is more likely to involve a caregiver medication mistake, whereas the toddlers are involved in their poisoning just because that's how they explore their world. Many families actually don't realize that they can call the Poison Center if they have a dosing error for an infant. They may think that they're going to get reported to Child Protective Services, but they can call the Poison Center and we'll help them out. And then for toddlers, keeping those medications up high and out of sight, because the kids are climbers and they're gonna, as I mentioned in my sister's case, they're going to go up and get it. You can also store your medicines in a lockbox. I have a lockbox here. You can get them at any big box store. You can store other things like cannabis in it as well. That will help the kids to not be able to get in it if you have something locked up. These are some items that look a lot like, you know, similar things. I have eye drops and super glue, diaper rash cream, and the toothpaste. You know, it's important to look at bottles and read bottles every single time. You know, people not paying attention, being tired, they can mistakenly put things like diaper rash cream on their toothbrush. And then it's important to remember to use the dosing product that came with the medicine. We don't want to use things like teaspoons or tablespoons because they're not accurate. And then making sure to pay attention to the fact that there is like infant acetaminophen versus children's acetaminophen, and using the syringe for the infant one versus using a cup for the child one. And then we're looking at what exactly supervision means. There was a study done by Snitzer that showed that a lower level of supervision, the greater the odds of severe injury. The children were more likely to be beyond reach and out of view at the time of injury compared to the control group, which was 1 hour prior to when the incident occurred. Plus, as we know, children act fast. Less supervision was identified as a risk factor. And proximity of supervision is important as well. Safe Kids also did a study that showed that parents overestimate their child's cognitive ability and underestimate their child's motor skills, which means that parents may think that their child will learn from past mistakes while not being aware that their child can climb up onto the counter. When I'm out at public events, I come across parents who think that their 2, 3, 4-year-old knows to drink or to ask before drinking something. I have like a container with just an unknown liquid. Usually I put some food coloring in it, so it's like a blue substance or a red substance. And then I say to the kid, if you saw this on the table and you didn't know what it was, would you take a drink or ask a grown-up like mom or dad or grandma or grandpa? And then sometimes the kids get it right and they say they would ask. Other times the kids reach out and grab it because it's something good. So it's a good lesson for parents to know that kids might answer correctly some of the time, but that's not always a good gauge and safeguard. And that's why it's important to keep medicines up high and out of sight, and locked up if possible, because those ages, especially 3 and under, are impulsive. So poisonings can happen when there is a change in routine. One example is visitors to the home. A lot of times visitors are grandparents, and those grandparents, you know, may not remember just because it's been a long time since they probably had a little kid. That kids act fast, and to make sure that, you know, you check with the visitor or grandma or grandpa to be sure that their medicines are up high and out of sight, and don't be afraid to ask them if they have medicines. You know, any kind of visitor, just have medicines or any kind of potentially poisonous product. Another reason that grandparents can be particularly troublesome and more dangerous is because they take a lot more medicines than other people do. And they're on usually long-acting medications, and they like to use those handy dandy little pill reminders, which aren't lockable. So like I have pictured here. So make sure that they store their Medi planners up high and out of sight as well. Just telling little Billy or Susie is not enough, because they're gonna see the pills and think that it's candy and something good to eat. Some other disruptions that can occur that can cause poisoning are if you're traveling, as I mentioned, house guests, time of day, when you're busy getting ready for school, people are in a hurry, when you're getting home from work or school and trying to make dinner, you know, that's a time when poisonings can happen as well. As Kirk mentioned earlier, he had a call about some children or a child who found an unidentified substance at a playground. Just be sure when you're at a public playground, do a quick search or like a sweep of the playground just to make sure that your child doesn't pick up some sort of a product, an unknown product. Also, making sure when you're on vacation, checking those vacation rentals to be sure that there's no loose pills on the floor that your child could pick up, because we have had calls where kids found a pill and ate it. Looking at some studies that we had in cannabis use in adolescents. The studies are really varying. There was a study that I looked at back from 2012, and it showed that adolescents are believing that regular cannabis use is not harmful to their health, and that adolescents are using cannabis at younger ages. And the ones that are using it at adolescents on a daily basis, they are finding in this study that it was neurotoxic effects from the cannabis, and that they wanted to highlight the importance of prevention and policy efforts and targeting adolescents, because they were seeing neurotoxic effects. And then there was another study that I looked at from 2014, and it showed that heavy cannabis use has been frequently associated with increased rates of cognitive impairment, particularly amongst those adolescent users, suggesting that the brain may be particularly vulnerable in adolescence to cannabis exposure. And then in the third study, it was from 2018, it looked at adolescents and young adult cannabis users. And this showed that the deficits may reflect residual effects from acute use or withdrawal. They weren't sure, so they suggested that future studies should be examined to determine individual differences in susceptibility to cannabis associated cognitive dysfunction. So the studies were a little bit all over the place as far as cannabis use and impairment. This slide just shows some different vaping products that are out there that you might see people use. This is courtesy of the CDC, this picture. I just wanted to talk a little bit about the effects of vaping on the lungs. You may have seen some news reports back in like 2019 where there were sudden and severe lung problems, including deaths linked to vaping. This condition was called e-cigarette or vaping product use associated lung injury, or EVALI. And according to the CDC, more than 2,800 e-cigarette users required hospitalization due to EVALI through February 2020. And 68 of these people have died, and most cases were in teens and young adults. Typically, the symptoms started gradually with shortness of breath and or chest pain, before the most severe breathing difficulty, which led to hospital admission, occurred. Experts are now attributing this or suspecting that the contamination was with vitamin E acetate in some of the THC containing e-cigarettes. And that was the cause of the E-Valley. Some other causes may be other contaminants or pre-existing lung conditions. Just some takeaways from the presentation. We're always here to help. Call us 1-800-222-1222. Save your number or save our number because you'll never know when you need it. It's fast, free, expert advice. Drugs are not always what they seem, as Kirk said, and we want to be sure to keep potentially poisonous products up and away and locked up away from those kiddos to prevent those poisonings. Thank you again. Here's Kirk and my email. If you guys have questions, I will turn it over to the EMSC folks to read out the questions.
Hi, friends. Thank you so much, Kirk and Mandy. There's so much information there. That's awesome. We do have a couple of questions. I know we don't have lots of time, but let's get to a couple of them at least. First question, can you reverse a nicotine overdose?
There's no antidote for it, but we can treat it pretty effectively. So number one, we discussed that seizures can arise, and we can control the seizures that arise from nicotine using benzodiazepines. So you'll need to be at least an ALS, a paramedic or above, to be able to administer that. And then with the respiratory insufficiency, we can always put an adjunct airway in there and intubate them until it's metabolized out of them. So very treatable, but no antidote to reverse it. Good question.
Excellent. Thank you. Next question. In the past, we were able to text poison to 484-848, and it would send us a return message with the Poison Center contact info to be saved in our phone. This is not working. Do you know if it was disabled or who to contact?
Mandy, do you have any idea about that? So our Poison Center does not use the text to poison. Some of the other ones within the coalition here might. So I can't say. Mandy's more in touch with the public side, and maybe she might know.
Yeah, there's actually a different number. It's relating to the fact that there was some issues with the type of card that they used or whatever. I'm not sure of the intricacies, but there is, for some reason, they did have to use a new system. I'm not sure if I'm using the correct vernacular, but that could be the reason why. I can look into a little further how you can save your number, or sorry, not save the poison help number if people are interested.
But the poison control phone number is the same for everyone. Is that correct?
Yep, it's the same number no matter where you are. If you're vacationing in Florida or California or in your home state, it's the same number.
And then we talked a little bit about what medics can do in the field, or even our folks in the ED can do when they suspect a poisoning but don't know the agent. And I think we all know that that's when we call you. What would you recommend for EMT level providers in the field who don't have meds to give? I mean, obviously they have intranasal Narcan, hopefully everywhere now, but any other tips for EMT level providers who don't have as many resources?
Yeah, that's actually a great observation and a really valid question. So sometimes if we don't know what the substance is, we can do what we call a constellation of symptoms, and that's called a toxidrome. So for example, some pathomimetic toxidrome is if somebody took methamphetamines, cocaine, too many Red Bulls, that kind of stuff. They all get tachycardic, they all get hypertensive, they might get hyperthermic. And the biggest one that I always tell, because I do teach EMTs and I am a state evaluator in our state to certify EMRs and EMTs, is the biggest thing they miss is skin condition and color. And so as you can see from the anticholinergic, if you take diphenhydramine, you're going to have dry, warm, red skin, but you're still going to be tachycardic and hypertensive. If you take too much caffeine, for example, you're going to be tachycardic, hypertensive, but you're going to be diaphoretic. And so knowing that those, we can kind of go through what we call it a fishing expedition, because we're not sure what we're going to catch. But we can go ahead and tell you if you tell us what the symptoms are, we can go ahead and tell you what we think what class of drug that it might be. And sometimes based on where you're calling from, maybe we've had experience that we've seen an extraordinarily amount of contaminated cocaine in that area, or kids are robotripping in that area. And if they look drunk, but they don't smell like alcohol, maybe they're doing cough syrup, and ask them, did you find any bottles on the scene? Yeah, there were some empty cough medicine bottles, and they're probably doing that. So yeah. And sometimes just calling us and talking it through just puts them at ease, knowing that there's somebody out there, especially with our rural providers at the basic level, right? You may be an hour to 2 hours to an ALS intercept, and you have this person and you're just like, oh my gosh, what do I do? We can, we should know what level that they're at on our side of the fence. And that's part of my job, is we staff with pharmacists, except for me. So a lot of times pharmacists don't understand the difference between ALS and BLS. So I teach them on our side of the fence what that is, what their capabilities are. And then on the other side, how we can go ahead and tell them what to do. And sometimes it's just nice to have that voice on the phone. I've been on that side of the fence, and it can be very scary, but I've always been in fairly urban environments. So I knew that ALS is going to be there. We're going to be at the hospital fairly soon. So those are just some simple things that we can have to offer. So great question.
Excellent. All right, last question. What is the most important thing that you want our practitioners and providers to know about kids and poisons?
From me, it's going to be treat the patient, not the poison. Everything is still ABCs. It doesn't matter if it's poison or not. Treat the patient, not the poison. We'll take everything else in consideration. That's my biggest message. Mandy? She's had real trouble getting off mute. Call poison control if you're in doubt.
Yeah, I like that. I like that a lot.
It doesn't have to be an emergency to call us. If we're busy, we'll let you know. We'll say, is this an emergency? No. And we may put you on hold. We very rarely do that at our center, but we're happy to go ahead and answer just questions too.
Very good. Very good.